At this time, I would like to welcome Dr. Hasan back to continue his education.
So, I was asked to talk about colonic emergencies, and it's a big topic, but what I've tried to do is focus on certain things that are a little bit more controversial that surgeons get pulled into, take care of, and then leave you with some practical take-home management strategies that you can use. So as opposed to talking about GI bleed or diverticulitis or perforation or volvulus, which surgeons take care of all the time, I thought we'll focus on certain more controversial things that straddle the arena between medicine and surgery, and we are often called in to take care of these patients. We'll talk about variety of colitis, C-diff, ischemic, ulcerative colitis, talk about some management strategies, some recommendations from different societies, and then try to put it all together in some easy-to-use algorithms. Now, if somebody has any questions at the end about something else related to the colon, I'm completely happy to answer it, but we'll focus on certain areas just because of the time constraint. So no matter what kind of colonic emergency you have, ischemic colitis or C-diff colitis, they all have this period of initial care. So it's not all about operating, it's about providing care to the patient. And if somebody, the way I look at it is when I walk in and say, does this patient need an operation? They have free air, diffuse peritonitis, stool in the abdomen, you triage him towards the OR, they still need a period of resuscitation to get them ready for the OR, but everything is sort of geared towards optimizing him, taking him to the operating room. Now, if the patient doesn't have that, you continue with the resuscitation, and then you implement the optimal medical management, and we'll talk about that a little bit for all these different conditions. It may require antibiotics, but sometimes patients, especially patients with ulcerative colitis who've been on steroids for a period of time, may require some supplementation of the adrenal support. They all need to be in an ICU, monitored care, and then you monitor these patients and make a decision about what to do depending on how sick they are. So this is where I think I want to emphasize sort of one practical take-home point. When I look at a patient, the sicker the patient is, the lower my threshold for operating on them. And it may seem counterintuitive because people say, the patient is too sick for an operation. The patient who's too sick for an operation is also too sick for having stool in the abdomen, too sick for septic shock. So the sicker the patient, the cardiac transplant patient on immunosuppressive who doesn't have kidneys, that's the patient you don't want to wait till they are going over the cliff and then try to salvage him. A little younger patient with better physiological reserve, they can sustain ongoing inflammation, sepsis, you can keep them supporting him and they still might bounce back. So it's a different way of looking at it. So the sicker the patient, the more elderly the patient, the more comorbid problems they have, the more likely I am to operate on them sooner rather than later. So let's start with C-diff colitis. You guys all know about it. We have a lot of nurses here. We have a lot of surgeons here. You all see it in your hospital. 15 years ago, it was a rare thing. Now it's rampant. Every hospital has C-diff. It's a huge healthcare cost, about more than $3 billion to the healthcare industry. Interestingly, if you look at healthy, non-asymptomatic adults, about 15% of them are carriers for C-diff. It's pretty striking if you think about it. Now, if you look at institutionalized patients who are in a nursing home or long-term care facility, about 60% or up to 60% of them are carriers for C-diff, and they're not symptomatic, and that's why we all have these screening criteria. When you come to the hospital, you screen the patients. What has changed over the last few years is the emergence of a brand new strain. The unique thing about the strain is that the regulatory gene that blocks the production of toxin is absent. So if you are infected with this strain of C. diff, the toxin that you make is about 20 to 30-fold higher than the conventional strain. So highly lethal, highly toxic strain, and now that's pretty rampant. So let's talk about how to diagnose. These are a number of different strategies. What you see on the top of the table are mostly for lab, serving as a reference strategy. So they're really down to the last two things that we typically use. Either we get an ELISA looking for the toxin, or we can get an RT-PCR. The difference between the two is they're both fairly specific, but the sensitivity is really low for the toxin. The problem with the PCR is that sometimes you can get false positive. It's a highly sensitive test. You can have a few bugs in there, and you can amplify the signal, and it'll still come back positive. But more and more, it used to be a cost issue, but if you look at the cost, they're fairly comparable. There's still about a 3 or 4-fold difference, but we're talking about $5 to $15 versus $20 to $50. So it's not a huge amount of cost difference. So at our hospital, we still use the ELISA for screening a generic average patient. For a patient who's got recurrent symptoms, not very straightforward, we're going more and more towards doing a PCR. Really available. You guys can just go to the websites and download them. So the bottom one is on the CDC website. It's a little old. It's about 5 years old, but a fairly comprehensive document that the CDC has posted on their web page. The top one is from American Society of Gastroenterologists. It's about a 2-year-old document, very comprehensive. Again, if you go to their website, it's freely available for download. And the middle one is from American Society of Colorectal Surgeons. Once again, they provided freely to anyone who wants to download it. So if you guys are interested, it's a problem that you see, I suggest that you just download these documents. Very good reference. So I'll try to pick out some pertinent findings that might be helpful for you as a take-home message. So I look at the C-diff colitis sort of like, the good, bad, and the ugly. So if somebody's got mild to moderate C-diff colitis, which we hardly ever see as an acute care surgeon, these are patients who show up in somebody's outpatient office, then giving them oral Flagella for 10 days is the recommended therapy. We hardly see it. Now, if you have severe C-diff colitis, then the oral Flagella is clearly suboptimal, and they should all be treated with vancomycin orally. If there is any reason that oral vancomycin cannot get to the colon, then you should also give vancomycin enemas. This is what we typically get, is the more fulminant C. diff where the surgical consult is obtained. These are the patients who have an ileus, they have toxic colitis, they are much sicker. And in these patients, you got to give them both oral and rectal vancomycin 4 times a day, and intravenous Flagella. So no oral Flagellas, both the strategies all at the same time. What you don't see here are the newer generation antibiotics. You don't see any IVIG. Those are all treatments that are for recurrent relapsing C. diff colitis. But for a first episode, this is sort of the full blast medical treatment that you give. And either the patient will respond or they won't. How do they correlate to each other in terms of cost? Just to get an idea, Flagella is dirt cheap. For a 10-day course, it's like $20 or so. Then you come down to vancomycin, the cost goes up, but it's still fairly cost-effective. And then the newer drugs like fidaxomicin is much more expensive, about $3,000 to $4,000 for the whole treatment. And that's why it's not generally given for first episode. It's given for recurrent or relapsing C. diff colitis or somebody who cannot take vancomycin for whatever reason. As a surgeon, you have to sort of make a decision when you see these patients who went to operate. So I'll give you some recommendations that come from our colorectal society. And if the patient fails to improve, and that's sort of in the eye of the beholder, I'll give you my impression of what failure to improve means. But if they fail to improve on medical management or they're getting worse, then you should operate. The standard operation is you take the colon out, leave the rectum behind. And now there is some emerging evidence, one center study with no really control, so the recommendation is pretty soft, but you can leave the colon behind, do an ileostomy, do a high volume lavage of the colon to wash out all the toxin, and continue with the medical management. Okay. So this is one of the studies that when I was at Mass General a few years ago, we looked at 10 years data. And I'll take about 2 minutes just to take you through it because there's some good take-home points here. The table that you see here is for 136 patients with fulminant C. diff. So this is not a walkie-talkie kind of a problem. This is sickest of the sick patients. And if you look at the 2 columns, the patients who are admitted to the surgical service versus the patient who are admitted to the medical service. Look at the first column now. So if they were admitted to the surgical service, 85% of them got a colectomy. The mortality was about 13%. If they were admitted, on the other hand, to the medicine service, a small number of them got a colectomy. Mortality was about 3-fold higher. And if they got an operation finally, eventually, the mortality was about 6-fold higher. And it's not that, and this essentially just points out that when they go to the medicine service, there's a delay in getting a surgical consult. By the time surgery is done, it's too little, too late. You know, we're talking about a 70% mortality of these patients when they were admitted to the medicine service. Now, looking at all of these patients, we sort of tried to figure out whether there are any variables that dictated who would live and who would die. And they were very simple, really. Age more than 70, white blood cell count either too low or too high, and cardiopulmonary failure, either getting intubated or getting any vasopressor support. Now, if you look at these 3 variables, all of them, 2 of them you can't control. Age you can't do much about, white blood cell count is whatever it is. So only the 3rd one is the one that's under your control, whether you can intervene before they really go over the edge. If you have one of these factors present, very few of the patients die. Mortality was less than 10%. Then it went up pretty rapidly to 37% with 2 factors present. And if all 3 of these things were present, you were old with a high white blood cell count, and you get intubated or get vasopressors, and about 60% of these patients died. So with this information, we created a couple of practical changes at the institutional level. And as a group, we all agreed that we'll operate on these patients quickly rather than waiting for them to sort of decompensate because the mortality was too high with or without surgery. Especially if you look at the mortality when the patient was on the medicine service and they call you, and the patient was on pressors and intubated, we were looking at a 70% mortality there. And then we went around and talked to our medicine colleagues and said, like, you know, patients with fulminant C. diff, call the surgical service as soon as the patient gets in, not on day 7 when the patient is dying. And with that sort of simple strategy, the mortalities come down to about 17-18% at Mass General now. Can you predict who will develop C. diff colitis when they come in? And the short answer is yes, you can, based on fairly basic physiological criteria. So when you see the patient in the emergency department, and if they have those, either if they're elderly, they have white blood count that's on the higher side, they are requiring pressors, the abdomen is tender, they may not have all the criteria for fulminant C. diff, but the chances that they will go in that direction is pretty high. There are 2 different scoring criteria, one they're using at Pittsburgh, one they're using, was this one that I'm showing you developed at Mass General. If you look at the area under the curve, you can predict with about 90% certainty, just based on the readily available parameters, who will get sick before they get sick. So there are 2 new things in the C. diff arena. One is this ileostomy, laparoscopic. Rather than taking the colon out, just bring an ileostomy, divert the stool, do an antegrade flush of the colon, wash all the toxin out, and continue with the antibiotic treatment and intraluminal vancomycin for the colon. They did that at Pittsburgh. The problem with this study, it's an excellent study. I think it's a paradigm-changing thing. But the problem is that they use historical control. Historically, 50% of the patients used to die. When they came up with this strategy, only 18% died. Most of the contemporary hospital, the mortality is down to 18% even with colectomy, so there is no appropriate control. And the second is that it wasn't one institution, there's no head-to-head comparison, but there are a number of places that are trying to do a prospective randomized trial. So if it turns out that this is as effective or more effective than taking the colon out, then it's desirable because at least your colon is still in place. Practically, I've done it, and if you guys are doing it, be aware that when you do an ileostomy and you still have the colon in place, the patient still has toxin in there no matter how much you wash. They will have a smoldering course, and they take longer to recover from the C. diff than if you take the colon out. The other thing which is getting a lot of attention is fecal transplant. And if you get beyond the sort of the ick factor, I mean, if somebody is going to take my colon out and give me a stool pill, I would take a stool pill rather than lose my colon and walk around with a bag. But this is a prospective randomized trial, small number of patients, published in New England Journal of Medicine, and they gave a donor stool pill post in the duodenum and compared it to vancomycin. So what you see on your left-hand side is how the microbiome changed. When you give them that stool implant or transplant, suddenly they have the normal diversity of colonic flora. And again, if you look at the response and compared to vancomycin, it is pretty dramatic. I mean, it's a small study, but it was a lead paper in New England Journal for a reason, because as opposed to doing an ileostomy and doing whatever. Now, these were not sick and dying patients, but since then, it's been tried in much sicker patients. Here, it was done not just as a pill, but with a colonoscopy, just spraying the inside of the colon with the donor stool. And again, when you can look at it, the response compared to vancomycin, so the response rate is about 90% with the strategy. If you're interested more in it, there are a number of review papers. This is very recent, just published this year. They look at all the published data about fecal transplant and the strategies and how to do it. There are different ways of doing it. What are the potential risks, transmission of diseases, and so on and so forth, how to actually implement the program. So it's not that you just take some stool and all you need is a stool in a blender. I mean, there's more to it. So let's try to put it all together and see, like, what would you do? And here's how we handle it. And we put together some of these algorithms for our residents and for our faculty members, so we have consistency and we don't do all kinds of crazy stuff from day to day depending on who's on call. So the way I look at this thing is, when you look at a patient, I try to figure out, based on the physiology, whether this is a good, bad, or ugly disease. What is the temperature, how many bowel movements they're having, white blood cell count, shock, whether they're in the ICU or not. Okay, so whether they meet the criteria for a fulminant disease versus not such a bad disease. Most of our patients, by the time a surgical consult is obtained, they are sicker patients, or they are patients with huge amount of comorbidities. So they are not sort of patients who are on the floor, they're usually ICU patients. And in these patients, you should give them oral vancomycin, enema, vancomycin, and IV flagyl. That treatment is started, and then you look at the criteria for mortality: age, white blood cell count, and need for vasopressor or cardiopulmonary failure. And my personal feeling is that if you've got one or two of these criteria, but the patient has some physiological reserve, you can continue medical management. Next 24 hours or so, 48 hours, see which direction the patient is going. But if the patient has got more than two of these criteria, all you need to do then is resuscitate and expedite an operative intervention. If you wait too long and they go over the edge, your mortality, even with an operation, is exceedingly high. Let's talk about some ischemic colitis. This was a relatively young patient whose colon I took out because he was on antipsychotic drugs and had a motility issue and came in with abdominal compartment syndrome and arrested with a colon this big. There are, again, a number of guidelines. This is the guideline from American Society of Gastroenterology about the workup. So now, again, if you have absolute indications to operate, free air, peritonitis, fine, go ahead and operate. Most of these patients, however, do not have transmural ischemia. They have partial thickness ischemia. They have high risk factors. These are generally sick patients. To getting a CT scan and getting a CT scan with arterial phase intravenous contrast to look at the blood flow to the colon is the right thing to do in vast majority of the patient if you can do it. Most of these patients don't have an occlusive ischemia. It's not like they have a clot in the blood vessel. This is a low flow state, so it's a non-occlusive mesenteric ischemia. So all the major blood vessels are open. But in case they are not, they have thrown a clot, then where you go, whether you go to a hybrid room, whether you take the clot out or bypass it, I mean, the strategy is how you approach it changes. So whenever we can, I think the right thing to do is to get some imaging studies to guide you. But the vast majority of them are going to be non-occlusive. Should you do a scope? Personally, I'm not a big believer in that. Bad things can happen. It's a threatened colon. You start encephalating it. You start putting a scope, and you can convert a bad problem into a worse problem. Doing a bedside limited sigmoidoscopy to take a look at the sigmoid colon is a different thing. And if the diagnosis is not clear, your CT scan is not giving you the answer, you might want to put a scope up there into the sigmoid colon to look at the mucosa. And the treatment is all supportive. Every time I get a consult from and one of these high-risk patients in the cardiac ICU and say, like, is the colon ischemic? And say, well, is the heart pumping or not? If the heart is not pumping well, for sure the colon is ischemic. but so are their toes, and so is everything else. So the treatment is not to take the colon out, but to improve the pump function so the colon can get some blood. Putting it all together, this is how I look at it. If you've got absolute indications, just operate on the patient. If you need to do a sigmoidoscopy to confirm the diagnosis, so be it. Otherwise, if you have the information on the CT scan, that's appropriate. And then over the next 12 to 24 hours, most of these patients, vast majority of the patients would not need an operation, they will get better. And I'll just finish with talking about fulminant ulcerative colitis, or toxic megacolon, another infrequent but fairly dramatic consult that you get on a patient who has ulcerative colitis and now come in dying. Very good guidelines from the Society of Colorectal Surgeons about who should get an operation and then when to operate. And there again, some practical take-home message here. So if the patient is not improving, they deserve an operation, and I'll tell you what my definition of not improving is. If the patients get worse on medical management, first line medical management, in the first 2 to 4 days, they should be on second-tier therapy, or they should get an operation. And if they are on second-tier therapy and they're not getting better, you don't want to prolong it too long. Within about the 5 to 7, maybe 10 days, within the first week or so, they should get an operation. Okay. So this is relatively fast if you think about it. So you don't want to let these patients languish and linger on for weeks, just getting sicker and sicker. And if you do an operation, the standard operation is you do a subtotal abdominal colectomy and ileostomy. And then later on, they can get some completion procedure. They may get a pouch. All that stuff is for a later time point. Again, you put it all together and try to come up with some kind of a strategy. This is how I look at it. You look at whether the patient has fulminant ulcerative colitis, and that's based on the physiology, tachycardic, temperature, hemoglobin levels, CRP, ESR levels, and how many bowel movements they're having. You start with IV steroid, pulse them, give them cyclosporin, the immune modulating agents as a second-tier therapy. And then very rapidly, either they will improve, or if they don't improve within the first 7 days, maybe even 5 days, then that patient should get an operation. Okay, so I'll stop here. If related to any of these things that we talked about or anything else related to the colon, I would be happy to answer any questions.